So welcome everybody. My name's Professor Peter Nash from Griffith University in beautiful downtown Brisbane. And today we're very lucky, I'm delighted to be joined by Professor Diego Kyburz from the Department of Rheumatology, University Hospital in beautiful Basel in Switzerland. Hi Diego, thank you so much for giving up your time. We're going to talk today about your recently published paper, which compared drug retention of the TNF inhibitors, the other biologics, and the JAK inhibitors in RA patients after they had discontinued a JAK inhibitor, which again we can discuss. So before we start, can you just give us a bit of an introduction about yourself, about the situation as far as JAK inhibitors is concerned in Switzerland, given the whole oral surveillance thing, and what kinds of things you're researching at the moment?
Okay, thanks, Peter. That's nice to have this opportunity to talk about this interesting data that we got, and also about the SCQM registry, which the data are derived from. So, I mean, the situation in Switzerland regarding JAK inhibitors is that we had tofacitinib licensed in 2013, so we were ahead of the other European countries in this respect. But of course, in the US, it was already licensed before. But we had a longer period of use of this drug in the real world, and that's why we got this data that we actually collected here for comparison of drug retention in patients that already discontinued a JAK inhibitor, because of course we have very good data from randomized controlled trials on the efficacy of JAK inhibitors in patients that failed methotrexate or also previous TNF inhibitor therapy. But in patients that discontinue JAK inhibitors, we do not know what choice of therapy we should make. And this was basically the basis for this study in the registry SCQM.
So tell us a bit about SCQM and how many of the rheumos in Switzerland put data in? Is it 100% cover or is it 50% cover?
Well, SCQM is a prospective cohort that contains patients with rheumatoid arthritis, but also psoriatic arthritis. We also have a registry for axial spondyloarthritis. This is all in the registry of SCQM included. This is not really population based because it's not mandatory to include patients there. There is a certain overrepresentation of patients on biologic therapy because often patients that do not require biologic therapy are not included, but they can be included. It's not only from centers, there are also private practice rheumatologists that can include patients there, and they actually do. So the coverage is fairly high because of that. We also include private practice rheumatologists, but it's not population based in the sense that we have 100% coverage. That's not the case.
Okay, and it's purely mandatory to put your data in. Would you say that since oral surveillance, the JAK landscape has changed a lot in Switzerland, or has it had very little effect?
I don't think that has changed a lot, but people are more cautious. I mean, there are more discussions what to do. There is certainly more awareness of the necessity to assess the cardiovascular risk profile in these patients. I think this has definitely changed, but I don't think that the use has already changed a lot. So they're still used, and there is some uncertainties. You can feel that there are uncertainties, whether it's a class effect, what has been shown in oral surveillance, or whether in general you have to be careful with these drugs. That's an open question, of course.
Okay, and you've got the three JAKs. You've got tofa, bari, and upa, which must have come fairly recently. And does the EMEA rule of over 65 and after TNFs, does that apply to Switzerland like every other European country?
Well, no, it has not applied in the same sense as the EMA. That's not the case. But of course, there was the safety warning that we're all aware of with tofacitinib, with this based on the data of the oral surveillance. So of course, the discussion in Switzerland is also whether this is something we have to consider for all the JAK inhibitors, which at the moment is not restricted yet.
Okay, so tell us a little bit about how you did the study, what your inclusion criteria were.
Yes, I mean, the study was done, as I said, with the data from patients in the SCQM registry with rheumatoid arthritis. So the inclusion criteria was, of course, diagnosis of rheumatoid arthritis. From there, we took the patients that had JAK inhibitor therapy and that discontinued JAK inhibitor therapy, irrespective of previous therapies. That was not restricted. So actually, a lot of patients had previous biologic therapies before they, discontinued the JAK inhibitor. So there was a broad range of previous therapies. Also, concomitant therapies were of course allowed. We didn't make any restrictions on co-therapy with steroids and conventional DMARDs. So it was a broad population.
And just on that point, is JAK inhibitors mainly monotherapy in Switzerland or still combo with methotrexate?
No, a lot of them were still in combination, but the percentage of patients that had combination therapy was lower in the JAK inhibitor treated. I mean, the patients that discontinued then restarted the JAK inhibitor. There, the monotherapy patients were more numerous in comparison to the patients that started with a TNF inhibitor therapy.
Okay, so tell us a little bit about your findings.
So basically, we looked at the drug retention in the patients that discontinued JAK inhibitor therapy and then switched on either a TNF inhibitor or a JAK inhibitor or a biologic with another mode of action. That included tocilizumab, that included sarilumab, that included abatacept, and also rituximab. And when we compared between these three groups, then we saw that the retention in the JAK inhibitor treated patients, so JAK inhibitor after previous JAK inhibitor, they had the longest treatment continuation. So the discontinuation rate was lower in this group as compared to TNF inhibitors. Okay. Whereas there was no significant compared to other mode of action biologics.
I should have asked, what was the commonest reason people discontinued their JAK to get into the trial?
Yes, that's a very interesting and also important point, of course. The most cited reason for discontinuation was not effective. So not effective was actually in about 55 to 60% the reason for discontinuation. There was no differences in between the groups that in terms of treatment after the JAK inhibitor. So it was 57% in the patients that were put on a TNF inhibitor. It was 55% in the patients that were put on a biologic with a different mode of action, and 63% in the patients that got another JAK inhibitor. So it was not less in the patients that were put on another JAK inhibitor.
So and you got no feel for how long they were on the JAK inhibitor before they discontinued?
Yes, they had, if I remember correctly, I don't know exactly this number. It's around 300 days, so it's a fairly long.
Okay, so they're on at least a year. And if we just look at that first baseline characteristics, these people had long-standing disease, 12 years or so of disease. They only 60-odd%, 70% were seropos. So do you have a lot of seronegative rheumatoids, or do you think that was other AxSpA patients creeping in?
Well, we hope not. We hope not, but it's true. Yeah, it's a little less than you would expect. It was... As you state correctly, between 63% and 78%, which is a little less. That's true. Well, I mean, we hope not. I mean, there are obviously also seronegative rheumatoid arthritis patients, which can also be included in the registry, and there are reasons for using TNF versus other mode of action biologics in these populations that might introduce a certain bias. You're right with that.
Okay, and you don't have a feel for which of the JAKs people did better on or worse on, discontinued differently coming into the trial? The numbers didn't allow you to say that?
Well, we would have loved to answer this question for you, but the problem is that, as I said, 2013, tofacitinib was licensed in Switzerland, and then for many years, it was the only licensed JAK inhibitor. That's why most of the patients that we look at that discontinued JAK inhibitor actually discontinued tofacitinib and were put on mostly baricitinib, because upadacitinib is only recently released. That's why we have a certain bias in the sense that we look at patients switching from tofa to bari. And this is why we also included a comparison of tofa versus bari in effect, also in drug discontinuation rate, but in a larger population of patients, because we had not enough patients in this population that discontinued JAK inhibitor to compare bari and tofa. And in a larger population in SCQM, we didn't find differences in drug discontinuation rate between tofa and bari.
Well, that's very helpful, and it is a very commonly asked question. I've got patients who haven't done well on a JAK or have had to stop for whatever reason. Is there efficacy if I switch to another JAK? So your study will help answer that question for us. So can you give us a feel for the percentage of patients who respond on a different JAK, having failed a JAK to get in?
Well, I cannot directly answer the question because we didn't look at response rates or remission rates or things like that. We just looked at the drug discontinuation rate, and I can tell you that this was actually better for JAK inhibitor than compared to another mode of action, biologic or TNF inhibitor. So actually, it's a good choice to use a JAK inhibitor after a JAK inhibitor, but which one, for that, we do not really have the data to make a comparison and tell you.
Sure, but drug retention is quite a nice surrogate for doing well and not getting side effects and continuing on therapy, unless they've failed every single other drug and they've got no other choice. So some of these people must have had a number of biologics and were sticking with the last one they could get.
Yes, that's obviously absolutely true. And we have in the table also in the baseline characteristics, the percentage of patients that have failed previous TNF inhibitors or also other mode of action biologics. And of course, the percentage in the patients that were put on a JAK inhibitor is higher than compared to the patients that were put on a TNF inhibitor. But statistically, of course, you can correct for that using multiple regression. And we did that, and did not influence the results that we got in terms of treatment discontinuation rates.
So that's very helpful, that you can change JAKs and get efficacy, or get retention anyway. And you can change to a TNF and not do quite as well as changing to a JAK. I was going to ask, is there any message in the side effects profile recorded with the different JAKs? Did you see VTE? Did you see any signals?
Well, we had single cases. Of course, the problem is what we looked at, we didn't really look at side effect rates. What we looked at the reason for discontinuation of the JAK inhibitor, the previous JAK inhibitor, but also of the patients that were then put on the different therapies. And then again, we looked at discontinuation and reason for discontinuation in these patients. And we saw single cases. There were single cases, actually 2 malignancies were reported. There was also a major adverse cardiac event, but these were single cases. So I cannot really tell you whether this was more evident in JAK inhibitor versus other treatments, because the reasons for the previous JAK inhibitor treatment we cannot compare, because that's just the population that we look at. But in the patients that were then switched to the different treatments, there we could look at side effects, and there we had no cases of malignancy, and we had also no cases of special interest. So this is not really possible to compare between the different treatments in our population. But in SCQM at large, we had done a safety study in terms of serious infections where we had larger numbers of patients. And there we saw actually the same as in the oral surveillance data, that the hazard ratio for serious infections was higher in patients over 65. And it was not different between biologics in general and tofacitinib in this case in under 65-year-old patients.
But I still think your data is very helpful, because these are real-world patients on concomitant therapies with comorbidities, on background steroid, etc. So important data. So thank you very much. Can you give us a take-home message then? Is there a summary of this study that you'd like clinicians to think about moving forward?
Yes, thank you. And I would like to encourage everybody to look at the actual data in the study, because there's a lot on side effects and adverse events that we have just discussed that are interesting, I think, to look at. It's descriptive, but it's interesting. The take-home message would be that in our study, we look at the population which has not been studied in randomized controlled trials that discontinue a JAK inhibitor, and we found that actually changing to another JAK inhibitor therapy is a good option in these patients. They seem to do well under this therapy. Of course, safety concerns have to be taken into considerations in these patients. We had some events of adverse events of special interest, but of course we cannot say whether these are different between the different therapies. But I think this needs to be followed up in other studies. But in general, switching from a JAK inhibitor to another JAK inhibitor seems to be a viable option. Excellent, thank you. I should have asked, is filgotinib in Switzerland, or is it early days? Excuse me, can you repeat? Is filgotinib available in Switzerland, or is it early days for that drug? No, it's not available yet in Switzerland. So we have no comparison. Only UPA has been so far for RA. All right. So thank you so much for talking with us today. We greatly appreciate it. We thank you for your time. I think people should have a good look at this paper because it does contain lots of important information for the practicing clinician. The JAK inhibitors are here to stay. We just have to find the best way to use them safely and effectively and individualize our choice. If you'd like to know more about this paper and the others uploaded to the CSF website this month, detailed slide sets are available in the publication section at cytokinesignaling.com. Please subscribe to this podcast on iTunes and give us some feedback and let us know what you think. And we appreciate your time and really look forward to analysing this paper in a bit more detail. Thank you so much.